Hi, my name is Vasilis Kalyvas, and this is my assignment for peripheral mobilizations. The case study I'm working on is a 19 years old football player who 6 weeks ago had a successful ACL reconstruction surgery. However, she is complaining for anterior knee pain, 6 out of 10, and she is unable to complete the last 10 degrees of knee extension. We start with the initial observation of the patient and their walking gait. While they're walking up and down, we check whether there is any visible bruising or discoloration, and we check from the anterior side the level of iliac crest, the level of the patella, whether they have valgus or varus knee, and the level of the malleoli. From the lateral point of view, we check for knee hyperextension, and from the posterior side, we check again for valgus or varus knee. Valgus knee would indicate that there is a weakness on the inside muscles or they have collapsed arches. And we check for single leg rotation and rotation of the calcaneus. Next, we have the functional tests, which according to Sanchez Alfonso 2011 can give quick information regarding the quality of movement of the patient, whether there is pain during movement, the active range of motion, and the muscular strength. Starting with a squat, we are trying to see if there is equal weight on both feet and whether they rely on one side more than the other for weight bearing. If the patient is squatting deeper on one side, that can indicate tightness on the quadriceps. Next, we have the lunges, in which we try to see whether the client has valgus or varus knee, and this special test is testing the power, the stability, balance, and the proprioception of the person. Last functional test is the single leg hop, during which we can see if the landing is smooth, if there's any pain on the patellar tendon, and we check also for the forward tibial translation. The single leg hop is a great test for the patellar tendon, which is the first decelerator when landing, according to Walker 2007. We continue with the palpations of the knee joint, starting with the sweep test. We can see with this whether there is any heat present or swelling around the kneecap, and we compare with both sides. Next, we palpate the structures around the patella, looking for fluid, and if there is any, when we tap the patella, it will bounce back up. We test the other side, the unaffected side as well, and we also palpate for muscle bulk. And we move the patella medially and laterally, superiorly and inferiorly, to see if it moves as it should and whether there is any pain present. We continue with the palpation across the joint line, feel for any swelling on the structure around the knee joint, such as the patellar tendon, the medial collateral ligament, the lateral collateral ligament, and the musculature around the area. Then we have the active, passive, and resisted movements of the knee, starting with the active ones, where the patient brings the knee into flexion and extension on their own, and we try to see if they can perform the movement easily and without pain. Then we check the length of both legs and if it's even, and we check the level of both tibias when next to each other, and if one is dropped, that will indicate there is an issue in the posterior cruciate ligament. Moving on, we have the passive flexion and extension of the knee, and when the knee is fully flexed passively and it feels like soft and mushy, that can indicate bad meniscus or swelling. We try the hyperextension passively as well, see if everything is alright, and we get the patient to resistingly extend their knee, so this way we put stress on the patellar tendon, and it will reproduce pain if there is a tear there. Continuing with the special tests, which according to Konin 2016 check the laxity and integrity of the ligaments. First, we have the Lachman's test for the ACL, in which we put the tibia forward with a sudden move. The test would be positive if the tibia translates forward. Then we have the posterior drawer test for the PCL, pushing suddenly the tibia posteriorly. It would be positive if the tibia is translating posteriorly or experience a soft feeling. Here we have the valgus stress test for the MCL, with one hand fixating the femur and the other one just above the medial malleolus, pushing outwards, putting this way stress on the MCL. The test would be positive if there were any gaps that could be seen and felt in the medial side of the knee or pain within it. Here we have the varus stress test for the LCL, which is located above the head of the fibula. This is where we would expect to see and feel a gap or have the patient experience any possible pain. To perform it, we fixate the femur and with the other hand we push the tibia medially. This puts stress on the LCL. For the resisted knee flexion, we firstly ask the patient to flex the knee and overcome the resistance from an extended position. This is a good test for hamstring tendons, which are stretched and under stress. Next, we ask them to perform the same flexion but from a further flexed position. This way, more stress is put on the muscle. To test the semi-tendinosus and the semi-membranosus, the tibia is rotated medially. By rotating it externally, we can test the bicep femoris. Finalizing the special tests, we have the McMurray's test for the meniscus. It is performed with the knee in a 90 degrees flexion, which is then compressed and rotated medially to laterally and vice versa. The test is positive if the patient has pain either medially or laterally by having the knee flexed with a rotation. Another test for the meniscus is the Apley's test. This involves rotation from flexed and extended position. When the leg is flexed and rotated externally, the posterior horn of lateral meniscus is under pressure. If rotated medially, the posterior horn of the medial meniscus is under pressure. Respectively, when in a 30-degree flexion, the anterior horn of lateral meniscus is stressed when it is externally rotated. We can stress the anterior horn of the medial meniscus by rotating it medially. As a first treatment, I used massage, which based on Zalda's study in 2008 was determined to be an effective complementary treatment for anterior knee pain. Effleurage was the main massage method, which according to Archer 2007 is indicated to increase blood circulation and lymph flow, so toxins and other waste products can leave the body. It has also been found beneficial to post-surgery cases, as it helps the muscle to be more pliable and can increase range of motion, as well as can help to identify trigger points. Trigger points are deep areas of tenderness within the muscle, and if released, the muscles can be loosened up. They are like muscle adhesions that can cause pain and restrict movement. As Irnich wrote in 2013, they form within soft tissues due to overuse, injury, and imbalance, and they can appear post-surgery. After the application of pressure on the trigger point for approximately 30 seconds, a light massage in the area will allow more blood flow. Trigger point technique relaxes the contracted muscle fibers in the area and increases circulation, which can help to remove waste products. In this case, trigger points were found during massage, and I applied pressure on the ones that are found on the vastus lateralis muscle and vastus medialis. Trigger point release in these areas can improve range of motion as found by Kuruma et al. 2013. As a last treatment, I chose Maitland's peripheral mobilizations. They are accessory movements which cannot be performed by the patient but by the therapist. They are used to reduce pain when done in grade 1 and 2 and to increase range of movement when done in grade 3 and 4, as Maitland wrote in 1970. First, I used patellofemoral glides, which, according to Banks and Hengeveld 2014, are indicated to decrease knee pain when the movement of the patella is medial to lateral and vice versa. They were performed in grade 2 to reduce pain, with large amplitude movement at within the available range of movement. After, I moved the patella from superior to inferior and back, glides that are indicated to increase knee flexion and extension, and they were performed in grade 4 to stretch the joint capsule and improve range of motion, with small amplitude movement at the very end range of movement. Next, I performed anterior tibiofemoral glides, which, according to Banks and Hengeveld, are indicated to increase knee extension. They are performed with one hand on the lateral malleolus, which distracts the knee, and the other hand on the tibial plateau, pushing it downwards to glide it. The tibia has to be laterally rotated, so there is not going to be any tension on the cruciate ligaments. This mobilization was done in grade 4 with small amplitude movement at the very end range of motion, indicated to increase knee extension by stretching the joint capsule. A study by Hunt et al. 2010 showed that this glide is beneficial to patients after ACL reconstruction with limited knee extension. Lastly, I performed a tibiofemoral distraction, indicated to decrease pain in the knee and increase range of motion according to Banks and Hengeveld. It is done with one hand above the ankle, creating the distraction, and the other one on the joint line. The tibia should be externally rotated to uncross the cruciate ligaments. A grade 4 mobilization was used with small amplitude movement at the very end range of movement.